I'm Carole Taylor. In this edition of Journal, I want to explore the messy, complicated, frustrating challenge our community faces when trying to solve the problem of addiction. We see the results of failed policy everywhere we look, on the streets of our cities and towns, where open drug usage is no longer unusual, and deaths from overdoses are sitting at 7 people a day in British Columbia last year. 7 people. Now, how could this be happening? How could this be getting worse when millions of dollars, thousands of hours of time by social workers, police, firefighters, politicians have been dedicated to this issue? Now, for sure, the influx of fentanyl, the deadly killer, has been a huge factor. But let me ask another question. Maybe have some of our approaches exacerbated the problem? Is it too late to rethink or redesign some of our initiatives, such as decriminalization or the safer supply of drugs? Wasn't the initial intent of decriminalization to simply stop arrests for small amounts of drug possession? It was surely not to expose our streets and parks and now our hospitals to open drug usage. And now many experts, including Vancouver's Deputy Chief of Police Fiona Wilson, state that through so-called diversion, these prescribed safer drugs often end up on the streets or are traded for more powerful drugs rather than being consumed by the intended addict. It's time for a thoughtful examination of these pilot programs. Joining me to take on this analysis is a man who has studied the problem of addiction and society's responses for decades. Dr. Julian Summers is a clinical psychologist and distinguished professor at Simon Fraser University, who has never shied away from asking tough questions, even if they're controversial, such as, how did we get here? And where do we go from here? Back in a moment. So, open drug usage, a safer supply, all kinds of issues that have come to the fore, and the public are very unsettled about this. So, Dr. Summers, I have to ask the question, how did we get here?
Over time. It's not a sudden emergence. Then for me, the backdrop really meaningfully begins with deinstitutionalization. In the mid-1980s, I was actually working at Riverview Hospital, 1987, and our job was explained to me, we're preparing people to move from the institutional setting and receive supports, and the government slogan of the day was closer to home. We are going to invest in resources that enable people to live and manage the symptoms of their illnesses closer to home, and that includes addiction. And we did the deinstitutionalization part. We didn't do the closer to home part. And in the decades since, I've been working with BC government, starting in 1996, doing policy advice and other governments. We've really failed in a really grand way to address this persistent gap. And instead, we have a kind of a patchwork. It's as though one side of our house fell down, and we decided we were going to make do with cardboard and scrap materials that we'd find. And everyone who comes in and analyzes the problem says, hey, you really need to rebuild this in a proper manner. But governments have never really felt the urgency. Many have recognized that need. When Senator Mike Kirby came in 2006 and did a national analysis of where are we in addiction and mental illness in Canada, he pointed to the same thing that I am and said, we need to invest in a large way in community-based, recovery-oriented systems. That was 2006.
And so in many ways, it's all backwards, because I sure remember Riverview. I was on city council, and they all of a sudden, because it was a North American idea that nobody should be in an institution, they'd be fine in the community. But it ended up, they basically gave you a bus ticket and off you went. The supports weren't there. And so now the idea of safer supply, and I think maybe you should start by describing what those drugs are, has taken hold. And I wonder, whose idea was this?
Okay, so that story also has roots. Starting with what's called safer supply, we reviewed this topic and elected not to use that term. Instead, we referred to a public supply of addictive drugs, or a prescribed supply. You can choose, but we balked at adopting safer supply because the title itself seems to imply that evidence of safety or effectiveness has already been established. And even today, that remains not the case. And if you look at the BC Centre for Substance Use and BC government materials presenting this practice, there's a disclaimer associated with each drug that they're promoting that says there is no evidence to support the effectiveness of using this drug in the manner they're suggesting.
So you're saying this policy is not based on evidence?
It is worse than that. Not only is it is not based on evidence. It's contrary to evidence. The Stanford Lancet Commission reviewed the North American opioid crisis a year and a half ago, Canada and the US in their orbit. And they listed over their 50 pages many, many things that jurisdictions could and perhaps should be doing in order to prevent new cases of addiction and help people who are currently addicted. They list two things that governments should be, in their words, skeptical of. One is introducing a pharmaceutical supply in the hopes of displacing the illicit supply. The main reason is what that tends to create is an overall increase in the drug supply in the population, not displacing drugs. The second thing they said we should not be doing is providing drugs to people from vending machines. Now, in BC, we are doing both of those things. They are central to our whole policy response. We almost couldn't have it more backwards.
So how did that come to be? Why have we accepted this?
Well, so a few people, I'm among them, had begun advocating for an alternative path, which we can get into a little bit. And the more, in my case, the more I advocated for consideration of an alternative path, the more I was excluded from discussions. And the people doing the excluding were a very powerful nexus of individuals working in practice, in public health, and in government, including our former provincial health officer, one of his two deputies, that worked very closely together on HIV/AIDS. They deserve immense recognition and thanks from British Columbians for the work they've done addressing HIV and really BC's contribution to that massive, massive crisis. Unfortunately, they seem to have believed that they had the same ability to have a beneficial impact on addiction. And they seemed so confident in their ability that they themselves formed companies that were poised to follow through on the advice that they were giving. So the former provincial health officer, along with the chief scientific officer from the Michael Smith Foundation, that's our provincial health funder, collaboratively formed an opioid company. The deputy that worked with the provincial health officer formed an opioid vending machine company. The director of the BC CSU, which is a group that formed from the old HIV/AIDS Center, himself formed a pharmaceutical company while serving as its director, all closely networked back to the HIV/AIDS days. They really appeared to feel quite confident that the approach that they were onto was not only sound, but was so sound that any appearances of conflict would fade in contrast to the good that came from their actions. Unfortunately, their actions were misguided.
And so the result is that with the safer supply, the idea that I've heard the former coroner and the medical health officer talk about is that, well, we're doing this to stop overdoses. That is the total focus of the supply program. We give prescribed drugs, and therefore they're not using the street drugs that are often poisoned, and so we'll stop overdoses. And that's obviously not working. And what in fact is now being admitted is that a lot of these drugs are being diverted. When the RCMP a while ago in Prince George had a big discovery of all kinds of these drugs that they came up with, everyone seemed reluctant to say, oh, well, it's connected to safer supply. They said, oh, no, it's just those drugs. But just last week, the deputy chief for Vancouver she said, absolutely, these are drugs that are diverted out of safer supply. So an addict is prescribed the drug, and maybe it's not powerful enough for him or her, and they go and they up the ante and they sell that, or they sell the initial package. So a lot of them are not using these drugs, but it seems that that's now part of the street atmosphere.
Part of what we got wrong in our conceptualization of the problem is that risk is somehow evenly distributed throughout the population. In fact, that was one of the original messages coming from this infectious disease group, similar to HIV, that everyone in the population is at risk. In fact, in the case of addiction, risk is very much concentrated. And it's true that any individual can have the misfortune to ingest a drug, they don't know where it came from, or they're not certain, and it's tainted somehow and it kills them. But if we look at the numbers of people that we're losing to this crisis, more than 2/3 are completely unemployed, have earned less than $500 in the year of their demise, and most were unemployed for years prior to that. Mental illness is disproportionate among people who we're losing, as is insufficient housing or abject homelessness. So we need to now recognize, if we don't already, that what we're introducing is essentially a fungible asset. It's not a meaningful alternative to the drugs that people are consuming. It's a source of money. And it's telling that that's the case. If we ask people, and research has done this, how could we help you? Many say, I'd like help if I could wish. I'd like help getting out of this neighborhood, and I'd like help getting a job.
And let's follow up with that in just a moment with Dr. Summers. So somehow we're way off track, it seems to me, in terms of how we're handling things. For one thing, I never hear anyone say recovery. They're just talking about keeping the addict supplied. So how do we go forward from here? Like, what is the answer? Do we give up on all of this and start again?
I don't think we have a lot to give up on, honestly. Although, if we go back to the 4 pillars, hopefully a familiar backdrop to many people, it starts with prevention, harm reduction, enforcement, and treatment. This is now a decades-old kind of framework. If we were to update it, we could focus overwhelmingly on prevention, recovery, which includes treatment but goes beyond that, and some version of enforcement, and embed harm reduction in both our prevention and our recovery-oriented. So it goes from 4 to 3 in a sense. Recovery and recovery-oriented systems is kind of the latest and I think well-justified policy frameworks that's current and that encapsulates how did Portugal or how do other places that appear to have made positive impacts, how did they pull that off? And here and it involves working across sectors, starting with the public sector. So all of our publicly funded services, housing, justice-related activities from police to corrections, health and social support, employment. It involves looking at how all of these interact across time for people. When we worked with 500 of the most entrenched, kind of stuck people living rough in the downtown east side, we interviewed them for homelessness and for mental illness. And when we select people based on severity in those two things, mental illness including addiction, fully 25% were in provincial foster care. Now, I don't know what fraction of 1% of the BC population was in foster care, but when you look at a severe social crisis and you find that 25% of the people in that plight were in foster care, that's a major opportunity for us to be looking at what went wrong. We published the results of discharge data from 5,000 people in St. Paul's who were admitted for addiction and mental illness, and they stayed for on average 3 weeks. Fully 1 in 5 were discharged to homelessness. And no surprise, they were likely to be back in the hospital in the next month. A recovery-oriented system fixates on those kinds of interactions across the board and ensures that we're not discharging anyone from hospital. That's a betrayal of the patient, and it's a betrayal of taxpayers to have that kind of practice normative in our midst. We shouldn't be discharging people from prison to no plan, no place to live, no support regaining employment. And unfortunately, these kinds of disjunctures, what we hear about in government as silos of practice, is very much the norm. We need to break that down.
So I was driving through Oregon on the very day that they decided in a vote by council to recriminalize rather than decriminalize. They were the shining light in America. They were going to show all the other states how it works. But there was such outrage in the community with the public disorder and the problems that it brought with it that they actually voted to recriminalize. So I guess what I'm saying to you, the mayor of Portland actually said, we got it backwards. We just got it backwards. We decriminalized before we had supports. So we've got to back up, get the supports in place, and then look at it again. So do you think that's where BC is? Are we going to have to just say this was a pilot that hasn't worked, so let's go back and build the support system?
Yes, put that way, yes. The evidence shows that we were not criminalizing people on the basis of drug possession before the so-called experiment. We looked at 14,500 people, opioid dependent. They had been on average sentenced 5 times per person. The total volume of crimes related to possession was 3.8%. Most of the offenses that they were convicted of involved theft because that's how they're forced to survive. The Portuguese had a very notable insight, I think, in their strategy, which was a very central commitment to social reintegration. So that's their framework. The reason they decriminalized, or one of the reasons they decriminalized, was so that police officers could approach people who were living in dire straits and engage them in order to bring them to the attention of dissuasion commissions. They didn't want police to be seen as a threat, as someone that's going to simply remove their drugs or their equipment, but give them a different look. The whole point was that they had built out the back end through these dissuasion commissions, some 60 therapeutic communities, lots of offerings for people to then move toward, which was the pathway to social reintegration. We need to do that here.
But what seems to have happened is almost the reverse, because police now have said publicly they now have no power to go in, even if somebody is being offensive or threatening with their drug use or blowing smoke at nurses or whatever. The police have no authority to do anything.
Yeah. We need to remember that problems of addiction at their core involve the experience of a loss of control over a behavior that's usually harmful to oneself and sometimes harmful to other people as well. And those syndromes, that plight is created. It doesn't exist in equal measure in all of our neighborhoods or in all regions of the world. We need to, beyond thinking about social reintegration, we need to think about prevention. There's no way to have a sustained 7 fatalities a day, month after year, unless we're constantly putting new people at risk. And we're 8 years into this crisis, and I have not heard a breath from our provincial leaders about what's our prevention strategy. What is our risk reduction strategy to attenuate those numbers? They're blind to it. A legislative reporter, Fran Yanner, has coined Safe Supply the war on drugs 2.0. And I think it's an apt insight because what she saw is that it looks different than the war on drugs, but the essential similarity is that all the attention is on supply. There's no focus on demand. And if there's one thing the war on drugs should have taught us, it's that a preoccupation with fixing our community-based problems by intervening elsewhere in the supply chain is insufficient. And here we are.
So here we are, and now I'm going to make you boss of the province or the country. What would you do today about decriminalization and safer supply?
I would fixate on building a system We don't need additional resources. I'll put that on the table immediately. We are spending, if anything, more than we ought to be in relation to this crisis. And I would focus on two things. One is promoting social reintegration among people who are currently at greatest risk. That has been shown to be done. Canada mounted the world's largest randomized controlled trials addressing social reintegration. That's a project known as At Home Chez Soi. It cost Canadians $130 million to learn the evidence from these trials. I had the privilege of leading the trials in Vancouver, where we focused on addiction. We've shown that many things that people say you can't do are completely doable. We routinely sell people and ourselves short in terms of what we're able to achieve. Landlords will rent units, people will move in, supports are capable of enabling them to move forward with their lives, et cetera. The other thing I'd focus on is prevention. We need to recognize that in our Indigenous communities, in many of our rural communities, the lack of opportunity, the feeling of the world is against me, is a direct contributor to more and more youth orienting to drugs and orienting to short-term experiences, because really, what's the point of sticking around anyway? And this is a very serious problem among youth. Affordability is part of it. We need to address those things.
Well, I wish you were in charge. But thank you for this conversation today. And I'm going to take parts of it that are hopeful, that there is another way of looking at these things if we turn it around and get the supports in place. And also just believe that many addicts really don't want to stay addicts. So thank you, Dr. Summers. I appreciate it.
Thank you.
Back in a moment. I agree with Premier Eby when he asks the question, how can you call it compassionate to let individuals lie on the street in a drug-induced state, clearly in need of care, and walk on by? And yet we do. This current model of decriminalization and giving out safer drugs to addicts without the social service supports necessary is not working. So the question for those in charge, can changes be made before the public demands the recriminalization of drugs, as they just did in Portland? I'd like to know your thoughts. Till next time, I'm Carole Taylor.